All right, hello everybody. So let's get to talking about antifungal agents. All right, funguses. How do they differ from bacteria? Well, these are different. They have a rigid wall, and they're made up of polysaccharides and sterols. When you think of like cholesterol, that's how I think of how fungus is made up differently than bacteria. They also have like this really thick layer around it, and so that is why antibiotics just don't work. It's just resistant to them. So you need special antifungal agents to kill off funguses. We have funguses that are mild to severe, and usually we all have some type of fungus on us. That's just how it is. But when it overgrows, it's usually because there's something going on with our immune system. So we see commonly with people with HIV, can easily are more susceptible, especially if their T cells are up because their immune system's down. Cancer patients, anybody who, like transplant patients, surgery, elderly, anybody can have a lowered immune system. We're even seeing more in younger patients, lowered immune systems due to a lot of stress and things going on in life. So there's systemic antifungals, which we'll talk about first. Usually with the systemic, I'm thinking more severe systemic things like a fungal pneumonia, but you can also have fungus in the entire GI tract. So with these, if you're going to treat with a systemic antifungal, and we're going to focus really on Amphisotarin B, that you should get a culture before and identify that it is a fungus before you just give an antifungal, because again, antifungals aren't benign, and we want to make sure that we're not giving them any toxic medications to them. Across the lifespan with children, there's no proven safety with kids, as with most of them. There are some that have established doses that we give to them, like if they have a yeast infection on their butt from diaper rash, or if they have an oral thrush, which is common. We can go ahead and give some nystatin for that. Adults, again, it can be toxic, so we have to really watch, and we have to make sure that they're given as prescribed. Older adults, again, they're more susceptible to it, but there's toxicity also, especially liver with these types of drugs. There's different sites of action of the antifungals, but the goal is to get through that layer. So when you see azole, you think fluconazole, clotrimazole, itraconazole. So these are all the different azole or azole medications, and these can be some are systemic, some are fungal. They aren't as toxic as the Amphisotarin B, and they don't work as well as Amphisotarin B. So Amphisotarin B is really used only for very severe, serious infections. Like you will only see that like given in AIDS patients or people that just have a serious fungal infection. These are given quite often. I prescribe fluconazole a lot, clotrimazole a lot for various fungal infections. If I see a lot of morbidly obese patients with a fungus rash under their breast area and skin folds, vaginal yeast infections. So that's when I go ahead and prescribe those. It's absorbed in the GI tract. Now, remember, like clotrimazole, I usually give as cream form. Fluconazole is more oral. That's your diflucan that goes to the GI tract. It's metabolized in the liver and comes out in the urine and feces. But again, these aren't benign drugs, so if they're going to be on these for a longer time, you want to check and make sure that they don't have any liver or renal issues with this. Also, pregnancy and lactation and drugs that prolong the Q2C interval. That's cardiac issues. All right, so and as you can see, there's many drug-drug interactions. So we're going to look this up if a patient's on some medications. Here's some examples of clotrimosoles. You can see a lot of these are just over the counter. In reality, these are pretty safe to just take for the recommended allotted time for just about anybody. But again, you don't want to overdo it. So it needs to be taken as prescribed or as it says on here. So if you can see, athlete's foot. This is a vaginal cream, clotrimazole. And we know we talked about antibiotic resistance. There's also antifungal resistance, especially to vaginal yeast infections. So this may not work. So then I have to go ahead and go to something else, like give a combination of diflucan with the clotrimazole. And I'll just monitor the patient's labs if I feel that they need to have that done. One thing I do also want to tell you about fungus is it takes a while to get rid of fungus infections. Remember, it has that thick layer, so it's very stubborn. And so it may take 3 to 4 weeks to clear up a good athlete's foot, sometimes up to 6 weeks. And then they have to take a break from it, and then it may come back again. So fungal infections are hard to treat. So they alter the cell permeability, which I just talked about with the wall, and it's preventing the replication and fungal death. So it's for local treatment. Tinea infections is your fungus, like athlete's foot, tinea crurus, which is jock itch, on the scalp, in skin folds. It's not systemic. That's why they're pretty safe to give those. The only thing it could do is cause some irritation, burning, rash, and then we would just stop the medications. Fluconazole, which I had mentioned, does come in a pill form, diflucan. And if you have a run-of-the-mill vaginal yeast infection, I can prescribe you one pill, and that should do the trick. Sometimes it takes 2 pills, so I'll say take 1 pill, and if 5 days it does not work, then take a second pill. Usually I prescribe 150 milligrams. If you look it up in Medscape, or if you look it up in Hippocrates or your Lippincott, there's different drug doses for different things, and there's different drug frequencies. You could give it once, you could give it twice a day. It just depends what they have going on. If you have an esophageal, if you have a scope done, an upper endoscopy, and they see fungus all down your esophagus, you're going to be on those medications for a lot longer. Amphisotarin B is another antifungal medication used for serious fungal infections. Leishmaniasis, which is like which you see a lot in underdeveloped countries. It's called a pollen class, which you don't need to know that. But what I just want you to know, it is used and reserved for very serious fungal infections, which we see like aspergillus, pneumonia, just fungal lung infections. And as you can see here, it comes in an IV form. Usually the pharmacist will mix it up, and it's compatible with dextrose and water. It's not compatible with normal saline or salt water, so it needs to be given with dextrose and water of some sort, and it needs to be transfused slowly, very, very slow. So remember that, because it can be toxic, and there's a lot of side effects to this medication also. So we want to monitor liver, kidneys. It can cause bone marrow suppression, so we're going to watch a CBC. Before the infusion, there's a chance of having a reaction. So let's give some Tylenol. Let's give some Benadryl to the patient to try to prevent those things from happening. Because remember, they're not getting this just for the heck of it. They're getting this because they're really sick. And then they need it. You do not need to know these, but just so you know, there is another class of antifungals. Which, to tell you the truth, I've never given these in my entire life. Okay, so Fluconazole, which is, remember, that azole medication, I want you to be aware that, remember, metabolizing in the liver, there's different pathways that drugs are metabolized, and there's the CYP450, cytochrome 450 enzyme pathway. It's a common pathway that many drugs are metabolized through. So remember, we were talking about statins and grapefruit, how they're metabolized in that same pathway. Well, it's the same way with this. So we want to be careful with giving other drugs and fluconazole, because they're both metabolized in the same pathway, so can kick one out. Remember the agonist antagonist? That's exactly what can happen. And yeah, as you can see, we treat it for like oral yeast. It could be from radiation and chemo causing yeast, athlete's foot, on the head, jock itch, vaginal yeast. All right, and clotrimazole is the other one that you have to know on your thing. So an example for this one too would be for tinea pedis or athlete's foot. So how are we going to tell a patient to do this? All right, let's go get some clotrimazole over the counter, and what I want you to do is when you're done washing in the morning, you need to dry, because fungus loves warm, moist places. They love skin folds. So if I see a skin fold with a rash, it's almost always a fungus, and because they just thrive in that area. So these people have to make sure that their skin is very, very, very dry, preferably air dry. It's very difficult because it's hard to air dry skin folds. Like if women with like larger breasts or obesity with the skin folds, it's difficult to keep it as dry as possible. But that's what we need to teach them, to try to air it out, put a fan on it, that area. And same with the feet. You just don't want to get out of the shower, have them moist, and throw your socks on. You want to dry your feet really well, put the cream on, let the cream absorb, and then right away you put on some clean socks and dry socks. Nothing moist, nothing wet. Also, we recommend maybe changing your socks during the day, because a lot of people that are prone to having athlete's foot sweat in their shoes in the day. Dry between the toes too. All right, and that's it on antifungals.